It's my land acknowledgement. This is mainly the territory of the Musqueam people, as you know by now. And it has been a teaching place for the longest time. And I do know that I'm the uninvited settler at this traditional ancestral unceded territory. Let me start with an overview. I will start out with addiction as an important mental disorder. And then I'll talk a little bit about translational crisis of current psychiatry. Then I talk about comorbidity, which needs to be recognized as a core foundational psychiatric issue and what it means. And translation research in clinical psychopathology needs to develop a common framework. This is my conceptual, it's very conceptual, the work. So please feel free to interrupt me or ask questions. I'll start out with some of you might be familiar with that. These are data, this is from the province, which reports the number of deaths attributed in 2014 to the substance use, the average age at the peak of the death, and that's potential years of life lost to premature mortality. So what you have, alcohol is traditionally the substance which has a very high level of deaths. The age is younger than in tobacco. And even though the tobacco has the highest number of premature mortality, overall people die, so to say, on average a little bit later, so that the numbers are much higher, while the overall mortality or years lost, healthy years lost is similar. Cannabis, I was surprised, to be honest, that they had any deaths attributed to it. I actually contacted the author because he did not explain the numbers. And he said that the two main causes were accidents, mortality driving cars, and the second one is COPD. That was the data here, he said, this is based on. The opiates, this is 2014. We are 8 years down the road, and the numbers have tripled by now. So that means we are now at the level of alcohol with years of life lost. And then you have cocaine and the other substances which don't really play that larger role. What I want to do is put that in relation. About 250,000 people die each year in BC. And as you can see, about 70,000 die from substance-related mortality early. You look surprised, Tony?
5 million people in the province, so a very high death rate.
That is 5 million for it's 80 divided by 80, right? That makes sense, doesn't it?
Number of years long.
Number of deaths 250,000. So it's four per million. No.
5 times
4 times 5 is 20. That's you're right. That seems to be very high. But anyway, yeah, but even then, if you say the number is high, then the relationship would be even higher. So I will check the number. The number of suicides about 4,000 in the province per year. And the average age at 2014 was 81.8, just to have a comparison of this data. The biggest problem, yes, sure.
Suicides per year, is it like they commit suicide because of the addiction?
No. Overall, I just want the comparison number because in mental health, we always talk about suicide being a very substantial risk, and a lot of risks attributed to the risk of suicide. And that's why I wanted to have this number of suicide as a comparison, right? So it's about 80,000 of substance-induced mortality, while suicide mortality is 4,000. Just to put it in comparison. And here's This is data from, I think also from BC, older data, as you can see, based on DSM-4. This is the probability of suicide ideation, which is from the 2012 survey. And what you can see, almost 10% have suicidal ideation, which I found quite high, to be honest, without any diagnosis. Here then we have alcohol use disorder, 80%, cannabis use disorder, 25%, other drugs, 35%, major depressive disorder episode, that is while they're depressed, about 40%, alcohol plus major depressive disorder, 60%, cannabis plus major depressive disorder, 60%, and other drugs, which is mainly then opiates and stimulants, 80%. So what you can see, there is obviously a high level of ideation, suicide ideation within the population, specifically not only with substance use, but also with increasing the risk if combined with MDE, which is not very surprising. Overdose death, a lot discussed about. Always the data, US 280, which is data from 2020. Canada is 170, which looks a little bit different if you do it by province. What I did here is I divided up the Canadian number by province. And we start out with BC. BC had 440 overdose deaths per mil. I think that is, yeah. So that is more than in about 42 states have, only 8 states have higher numbers of mortality than BC in the US. The US is supposed to be the by far leading nation regarding overdose. So this is interesting because BC is 140, Alberta 330, Saskatchewan is 200, Ontario is 170, and Quebec is 60. So there's a huge gradient in the overdose mortality within Canada. And it's interestingly very consistent from west high and the east the lowest. And if you look at it, Quebec has numbers which are more closer to the European numbers, like France has 7, Portugal has 5, Netherlands has 15, Germany, which in Europe is considered to have a huge problem, it's 90. And then you compare to 404. Different topic. I wanted to emphasize why I think addiction is very important, and I also think that it's still underestimated how important it is. Translational crisis of contemporary psychiatry. This is a paper which came out recently, which talks about translational crisis of contemporary psychiatry with a crisis of mechanism and a crisis of subjectivity. The crisis of mechanism is that there's a lack of understanding of the mechanism. We have not developed biomarker, and there is a stagnation in the development of medication. And I think that is something we have been seeing. I don't know if everybody would agree with there is not a development in understanding the mechanism. I think there is development, but I think we all kind of like know that surprisingly little new medication have come up in the last 20 years. I don't know if it's a crisis of mechanism, but obviously the mechanism is, or the understanding of the underlying mechanism has not yielded the results we were hoping. Crisis of subjectivity. I don't know if people would underwrite that, everybody, but there is a neglect of essential subjective nature of the psychopathological symptoms with the experience in first-person perspective. There's an inability to intimately connect subjectivity to the third person, the observation of the brain's neurocomputational mechanism, and there are only few semi-structured interviews. So one thing is, not everybody would probably agree with neurocomputational mechanism because the computer picture is a little bit being discussed. But obviously, there's one thing which he addresses, which is in my picture, and that's what I want to talk about, the lack of connection of the psychopathology and the clinical diagnostic system with the current neuroscience. And being from Germany and having studied in Munich, where Kraepelin lives, I had to go back in history. And what we have is the development of the biological psychiatry by Kraepelin and the phenomenological psychiatry by Franz Jaspers. Kraepelin interestingly studied with Wundt, who was the first psychologist who tried to measure psychology. So he wanted to become a psychologist, but as a psychiatrist, to make no money. He is the founder of the biological psychiatry, acknowledged, and he focused in the diagnosis on the clinical course. And I think that is something which is still important today, that he developed this concept of the clinical course as the major indicator for psychiatric diagnosis. Then Franz Jaspers, he studied law, medicine, and philosophy, and he actually became a philosopher after he had written the General Psychopathology. And he is the founder of the phenomenological psychopathology. So phenomenological psychopathology is kind of like asking people about their subjective experience. So if you're depressed, what is it you're feeling? What is being depressed? What anhedonia? What is anhedonia? So he comes from a philosophical concept where the idea is that you need to explore, so to say, what's going on in the mind. And he was more along the line of what can we measure and how can we make a diagnosis. And he came up mainly with the clinical course. So we have this kind of setup originally between the behavioral more, I would say, and the subjective approach, which is still kind of like playing a role in clinical medicine or clinical psychiatry. One thing I think which is sometimes misunderstood or sometimes understood is obviously there's big differences between subjective experiences and objective measurable experiences. And for the longest time, really, the idea was let's get completely rid of the subjective experience, and the behavioral approach made actually kind of like focus completely on behavior, measure behavior. Now we have cognitive behavioral pharmacology, which does actually to some degree include subjective experience. This paper actually went through tons of papers and rated papers and we conclude that despite views to the contrary, first-person experience has always been and is still central to investigation of the mind, even if it's not recognized as such. We suggest that conversation ought to be reframed instead of debating whether to accept subjective first-person knowledge, we should discuss how to best do so. So I think this is one thing which is creating some of the dissatisfaction, I think, in clinicians, that they are utilizing an approach, they are trained in an approach, and their cultural background makes these subject experience a very central topic. And they feel that, so to say, it's nice that we can explain what's going on in the brain, but it so far has too little impact on my clinical work. This is again the idea that we have these third-person data, but we actually indirectly are also using first-person data in at least some human neurobiological research. So what I think going forward from a clinical point of view, for clinical research, is we need to find a common framework. We need to find a framework where people use the clinical neuroscience, but also kind of have a way of, in some way, integrating systematically the subjective experience. There is some suggesting like first-person neuroscience, like neurophenomenology. And I think the important thing is that we are a little bit stuck in developing the clinical pictures. And we are a little bit stuck from mainly, I think, the clinical side, that you have little way of, or little interest in improving the understanding and processes, clinical processes of mental disorders. Like we had this discussion this morning, it's not about subjectivity, but overall clinical research doesn't have much value at the moment. So there's not a single head of the department in Germany, US, or Canada, I think, who does actual work on the clinical patient. There's always work which works with patient, but utilizes generally other approaches like neuroscientific approaches. The actually phenomenon is very little research, and there's those problem those who do a little bit of research, they are not connected to the clinical neuroscience. So I think that is why you need a shared framework, so that it's not this against this, but that there's a way of kind of communicating and integrating, which is not easy because obviously the data are very different. There's another component which I will not go into as much, which is at the same time the two of Kraepelin and Jaspers were working. Actually, Jaspers is a little bit younger. There was a guy in Vienna who was professor of neuropathology, histopathology actually. And in Vienna, when you kind of work as a professor in the university, you don't make much money. So all of the professors see private patients after 5 o'clock. And the patient he saw after 5 o'clock as private patients, that are the patients where he started to look at the psychoanalysis. So it was not actually part of his academic work. This was kind of like independent. The problem is that at the time, obviously, he found that some of the conscious processes, which a lot of clinical the clinicians work with, is problematic, right? Because the decision making and the conscious processes are not as clear and straightforward, but there's a lot of decision making which doesn't seem to be based on consciousness. So he stayed within the mind frame, so to say. He never was able to go to what he really wanted to go to understand the underlying brain processes. And but the important thing is, I think, that the connection between the conscious thinking and the behavior and brain behavior or the brain activities is way more complex than conscious relationship one-to-one to processes. And I think that these kind of problems have not been really integrated into approaches, and we have separate worlds which are more or less fighting each other. So this is about translational crisis. I don't think it's a crisis. I think it's an ongoing problem which has not been solved. Then the next topic, which is a little bit related but not really, is comorbidity needs a recognition as a core foundational psychiatric issue. This is a registry. Scandinavian countries have large registries where all the psychiatric patients are registered. And what you have here is this, I think, substance use disorder. And they have like 120,000 people in this registry. And what they did is just look at combinations. They had 6 groups: substance use, anxiety, affective disorder, schizophrenia, personality disorder, and dementia. And then they looked at just the diagnostic criteria. And what they found is only 27,000 of the 120,000 people they looked at had substance use only. When you look at here, substance use and anxiety disorder, it goes, the groups get smaller and smaller, but there's nearly all combinations. And there's only a small subgroup, and that might even be young people, right, who has not an additional diagnosis. And then they looked actually at what came first, and it seemed to be almost random. So that it seems to be a very strong overlap of mental disorders. This is schizophrenia, 73,000. 19,000 of those have only the diagnosis of schizophrenia. Again, the same picture, and you can come up with other diagnoses. And it's the same picture over and over again. You have combinations here. The most common combination is schizophrenia and substance use disorder, then schizophrenia affective disorder, and then here triple combination, and so on. But the point is, there is a huge hodgepodge of diagnosis. And actually, the concept that the person has one diagnosis is less than 25%. There's a lot of discussion about concurrent disorder, dual diagnosis, dual disorders, concurrent disorders, dual pathology, and it's always mental health and substance use disorder. But I think this is kind of part of a bigger picture where substance use disorder is one of the mental disorders, and you find overlap a lot between the different disorders, including substance use disorder. The only reason why I think we focus on these two is because treatment has been separated, and so the psychiatrists have not been considering substance use disorder as their job. And the people who have picked up substance use disorders generally were non-psychiatrists who didn't see mental disorders as their job. So I think there's a little bit of artificial separation, but the more important picture is, I think this is part of a really kind of like picture where there's a lot of overlap between these disorders. The general discussion is then what comes first, addiction or mental disorder? Does addiction induce mental disorder, the other way around? As I said, the one thing to look at is what was first. And the data were not convincing there's a direction. Also, you have to see there's age of onset. Obviously, anxiety disorder has an age of onset in the adolescent, while mood disorder comes in the 20s. So you would always have more anxiety disorder before substance use disorder than mood disorders, simply because of the age of onset. Then, if it's not one inducing the other, we have also the possibility that there's overlapping genetics, there's overlapping risk factors, and then it's the same brain. So I want to try to talk a little bit about these different levels and overlaps. One is when you look up individual genes or genetic factors, there's a lot of overlap actually with they are not very specific. There are some specific ones for alcohol, for example, the ones with pharmacokinetic of alcohols, the metabolism of alcohol. Obviously, that is very specific. But here they look at comorbidity risk, which is probably convened by genes engaged in neural development, connectivity, and signaling. So there's a core group of genes which seem to be kind of like active at different levels. And this has been published more recently, more often. This has been around for 10 years. That's an older version of this is the heritability gap. What it shows is twin studies show quite large heritability. But when you look at the molecular or at the gene level, how much does it explain? It never comes to more than 25%. So when you read the paper, they never give you these number of the so to say variability explained or the effect size or something. They always start out with the heritability with 60–70%, and then they switch to the specific genes, and the specific genes is actually not that convincing. This is the Manhattan plot. And this is the one here, which is based on 180,000 individuals, the cut M2. And what they showed here, this is the one which was the highest effect size for cannabis use disorder. But the cut M2 is also relevant for schizophrenia and a number of other mental disorders. And I actually dug through about 20 papers till I found an effect size, and the effect size was less than 0.1. So if you kind of like translate this into something like height, you know, if you have one person, average person, 175 or something like this, it's 4 millimeters, which explains. So, wow. This sounds terrible first, right? So you need 180,000 people to find it. And then the effect size is, I mean, there's a lot of work in this. There are 100 people involved in studying this. And this is the one which obviously stands out, right? So, but I'm not going to go into that. That sounds terrible from a clinical point of view. But this is actually from the same paper. They did kind of like studies in knockout mice, right? And in knockout mice, they could show effects of this specific gene. Why could they show effects? Well, if you control for a lot of things, if you control for other genes, like use inbred mice, if you control for the environment, if you have a good experimental kind of like controls, then you can change, obviously, the impact and target the impact of this specific gene. And I think my point is, even though the effect size from a clinical point of view is very low, it still is something which is important in understanding the mechanism. And that is something also, I think, which is important to understand, is that when the average effect size is low, there is variation in the effect size depending on the environment. And the environment includes other genes. So it might in individual have a higher impact, but on average, in the general population, it's quite far away from the phenotype. And I do still think we need to understand it, we need to study it. But the hope that this leads to an immediate medication or something like this is kind of like, pharmaceutical company realized that 15 years ago and pulled out of it. There's another study where I was involved, where we looked at pharmacokinetic testing of antidepressants, and could show that it's worthwhile to do pharmacokinetic testing, because on the other side, if you look what clinicians do, they give patient medication, and then they wait if it works. It doesn't. Take the next one. Wait again. Take the next one. Wait again. So it's completely random. And I know when I started out at he was a successor of Kraepelin. So he was a big guy in Germany. And I started out and I was anxious as hell. And so he asked me, so what kind of antidepressant do you give him? I said something, he said, okay. And he always said, okay. And I at one point asked him, I don't know that much about antidepressant. How can I always be right? You know, you have to trial. It doesn't matter what you start out with. There is no good. There are side effects, right? So you try to avoid some side effects, but beyond that, it's poor. So, but if you have kind of like pharmacokinetic testing, you can have an impact on side effects and so on, so avoid some. But anyway, we could show that this will kind of improve the impact. Just to say that while I'm very critical with clinical with genetics per se, there are aspects of it which are important. It's important to understand that it's again very complex, and that the hope of a lot of people that you will, like this, get the medication from it is probably not there. Environmental factors very big field, very difficult. He has home, friends, trauma, cultural. And the one which has gotten the most attention recently is trauma. And here, you probably know that also, if you look at adverse child events, it's very unspecific. It increases the risk of drug use, that is 4 or more adverse events. Alcohol, I don't know why smoker is lower. Mental disorder, anxiety, depression, but also other physical disorders. So again, we have genetic overlap to some degree. We have this environmental risk factors, which are kind of somewhat unspecific. And this paper really kind of like I found quite interesting. I don't have a stone bar. He did a meta-analysis looking at the voxel-based morphometry, and this is resting state. And he found actually that there were some areas which lighten up in all psychiatric disorders. And he is one of the few who included also the substance use disorders. And he said these areas he kind of identified where you could attribute to 3 main factors. One is salience. So there seems to be some salience aspect in most mental disorders, which is the selection of environmental factors or something what sticks out. Commercials love to use salience. Is my commercial salient? Doesn't stick out. Then I tried to again go back to the clinical neuroscience, but different perspective. Salience is obviously something we can to some degree measure. When we come to meaning, it becomes a little bit more difficult. The second is cognitive control, flexible adaptive responses, and goal-directed decision-making. Again, cognitive flexibility, conscious planning is in the clinical stage. So there is something you could kind of like combine and make clear how these are related more concretely, right? Not as vague as I'm putting it down here. And then it's response inhibition, suppression of inappropriate action. I love this one because I find impulsivity to be very important. And so that is actually response inhibition, and this is willpower to stop habits. I have a lot of discussion with my patients on willpower because they all tell me they use the willpower to stop. We know from data that you have to have a rehabilitation, so you have to develop different habits and train differently. But interestingly enough, contingency management is very effective. But a lot of people, when you ask it afterwards, did the contingency management help you? Said, well, it was very nice to get the money. It had nothing to do with the money. It was my willpower. So there is a discrepancy between kind of like the conscious decision-making here, which is based on the willpower, and actually the impact from environment or the contingency management, which obviously had an impact. I kept on, these are all overlapping mechanisms, which I think are important. I really like Kahneman's System 1 and System 2 approach, which is the dual process, where he says we have decision-making more intuitive, more fast, more immediate, myopic reaction. The effort is low, it just happens. It's very habitual, but automatic. It doesn't have to be conscious. We don't have to think about when we kind of like react to something immediately, like if we hear something noise or so, we don't think about, okay, now I take my hands and put them over my ears. Bias risk is high, obviously, because it's, and then you have the System 2, which is more the analytical system, which is slow, high effort, a lot of conscious involved. It's not clear if that is kind of like higher or lower in the sense, or if it's more conscious. Then bias risk is lower, obviously. That's why we plan our science to avoid bias. Cognitive control, I would put that onto, and this is habitual response. So actually, in principle, you have the salience, and then you have again the better cognitive control reduces the risk of mental disorder, and better control of habitual response reduces the risk of mental disorder overall. We had also done meta-analysis looking at impulsivity, for example, in patients who have a depressive disorder, but they have also higher impulsivity. Automatic process controlled. There is also some, obviously, some brain regions which are more associated with it. Actually, people also like to talk about bottom up and top down. So there are different names and different concepts, a lot of different variations on that. One thing why I promote stress research is because I think stress helps us to flip from a more kind of like cognitive controlled to more impulsive response. I don't think it has been demonstrated that well. I'm always surprised that there is not more research on it, because in a stress situation, we need to respond more immediate. And so we are generally kind of like reacting different from if we are not stressed. More impulsive reactions. Going one step further, if we look at symptoms, there is actually a huge overlap. I have a lot of discussion, for example, with people about inattention, right? So they tell me if they have ADHD because of inattention. But if you look at it, bipolar disorder, depression, and substance use have also inattention as a symptom. So this is not really differentiating very well. And there's a lot of kind of like things which are overlapping in the symptomology. So we go from genetic over environmental factors, over brain regions, to even symptom level, where we have this kind of like confluence or this overlap in symptoms. People have tried to develop systems based on these symptom structures. So this is not going back to the neurobiology, but simply on the symptom structures. And they came up actually that there is self-emotional dysregulation is a general marker for all disorders. And then externalizing, internalizing has been around for a long while. There's the other system, I'm not going to go into details, who try to do the same, just trying to develop something like an internal structure of the mental disorders based on symptoms. I think that we need to, sure, go ahead.
Yeah, because we have like the dichotomous DSM, and we also have the research domain criteria.
Yes.
And would the research domain criteria be closer to that?
I'll get to that in a second, okay? Yeah. Yeah, I think this kind of like core structure or core understanding is built on symptoms. I think we need to start to develop a framework where we also understand the other overlapping aspects. For me, actually, the brain part is the most important part, because that is, so to say, the crossroad. Genetics is very kind of like hard to kind of like work with these small effect sizes. Environmental risk factors are very unspecific. So I think we need to connect these symptoms more and develop better assessments within these symptoms. We cannot throw away the diagnosis because that's what the system built in, but understand more the overlap and the internal structure. Okay, that's what I was saying. Translational research and clinical psychopathology need to develop a common framework. There is an approach. Obviously, I'm not the first one to come up with the idea that clinical work and neurobiological work are not kind of like working that well. I think the research domain criteria came out 10 years ago, and it's 5, I thought it was 6, but anyway, it has like assessments of approach behavior, avoidance behavior, approach behavior, some cognitive group, which is a little bit, again, here, cognitive control, a mixed bag. Then these are social, which is like agency, self-knowledge. It's kind of like it's an attempt to develop a structure and develop some guidance regarding transdiagnostic approaches. But I think it cannot be more than the first step. I think it has to go beyond just taking one test and going through, but understand more the underlying connectivity and of the different disorders and the underlying structure. So RDoC, was it successful? No. There were 1 or 2 attempts. Actually, I reviewed one paper which tried to combine RDoC with DSM-5. And big names on it. It's, I think, one of the worst papers I've ever seen. It was like terrible. And I think the problem is that you're not kind of like developing a common framework and integrating things, right? So the hope was that this would kind of like develop itself into something, but I think there needs to be a more active interaction between the psychopathology and the mainly clinical section. Finally, to treatment. Cognitive behavior therapy was developed for depression, but it is used in a number of different no, it's not the way it's set up. But anyway, it's used in a number of different diagnoses. Now we use CBT for an addiction, or part of it. We use CBT for anxiety anyway. So I think the principles of cognitive behavior psychotherapy have been expanded and more applied to different diagnoses. When we do treatment with medication, we don't necessarily stick to the rules of the diagnosis. And there's obviously some rules, right? But there is a lot of kind of like here, antidepressants were developed to treat depression. They treat obsessive compulsive disorder, bulimia, social anxiety, PTSD, panic disorder. And sometimes, I mean, I work in a tertiary, I go completely out of the box. I mean, I have a patient who is psychotic, who has delusional ideas which are very grandiose. He's not really manic, but very grandiose. And so I tried the mood stabilizers. The clinical book. But he had tried everything, right? And it worked. The delusions went away. So it is strange. I mean, I'm not saying that's willy-nilly, but again, we have crossed borders, and we have started or regularly use medication, not targeting diagnostically as precise as discussed. This is antipsychotics. They're used for schizophrenia, for bipolar, for delusional disorders, as an add-on for major depressive disorders, obsessive compulsive disorders, and substance use, and so on. It doesn't mean that they always work and that it's always a recommendation. My point is more that the specificity which medication are supposed to have is not there. This is a study we did, clozapine. We did clozapine medication, and this is actually observational study. So in clinical work, it's not always possible to do a clinical trial. So this, I think, based on 70 patients we had. We looked at, we looked at relapse with stimulants. If patient on clozapine did much better than the patient on any other antipsychotic. So this is not completely new, but the other factors positive is younger age was more associated with relapse. If you look at these, were not significant. When we tried stimulant as a substitution therapy, it did not work. It made them relapse. And these are all not significant. So I think why I show this is that obviously, if we have this kind of combination of disorders, we also start looking at what does it do with the other disorder. And specifically, if you have a substance use disorder, like schizophrenia here and substance use disorder, it's also important to know, does it have an impact on, in this case, stimulant use disorder? Or, and when it's the case, what makes it happen? Is it that they're simply doing better, or is it some other aspects? Talking transdiagnostically, we are now seeing the TMS coming up. We are also doing TMS research. TMS is quite transdiagnostic. If you look at it, they use similar targets for a variety of disorders. Again, kind of like impacting not as specifically as you would like the impact. One thing which is nice about TMS is that you kind of change the activity of the brain. And with fMRI, you have potentially also something where you can measure activity, regional activity. With medication, it's more like the PET studies or the preclinical studies where you have to go to do the studies. While with TMS and brain mapping, you have a little bit more opportunity within the clinical work. We are running also psilocybin study again, and a treatment approach which is thrown all over the place. It's we do substance use disorders, depression is being done, eating disorders is being done. So it's again a very transdiagnostic approach. So my point is that also from a treatment point of view, we are, if anything, probably seeing more of the kind of unspecific approaches. Let me summarize. Addiction is a mental. Oh, good. Yeah. Addiction is a mental disorder sharing core mechanism found in other mental disorders. Comorbidity is a rule, and we need to develop a framework which looks beyond individual disorders in a transdiagnostic approach. And I think we have transdiagnostic approach, but we need the framework. And we need to develop a framework which integrates clinical and preclinical research to a better degree. And this is just from the Harvard Catalyst. Anybody doing translational work probably knows that. And these are the 4 big ones in translational research. You have to train the people, so to say, develop a culture. You have to connect. I think we will see way more attempts or needs to kind of include knowledge which is very diverse. So connection not only means connection within your field, but also outside of your field. You need support. Obviously, these are very complex disorders we are looking at, very complex approaches if you go into the clinical realm of it anyway. So you need support, and you need to be inclusive, which is currently, for example, with the psychedelic studies, 90% white and 90% income over 100,000 so far who have done.